Hi, we're here at HIMSS 2017 in Orlando, Florida, and we're talking with Nandini Rangaswamy, Executive VP and Chief Strategy Officer at ZeOmega. Welcome.
Thank you.
We've been talking about the advantages and the disadvantages between an EMR-based PHM and a dedicated PHM. And what do you think are the key opportunities in both in that payer-provider collaboration?
So it fundamentally goes back to what I was talking about. How do you manage the clinical and the financial risk of the member? So if you're, or the patient, a member if you look at it from a payer's perspective, a patient if you look at it from a provider's perspective. These elements of clinical and financial risk are being embedded in value-based care contracts. Whether a physician or a specialist or a hospital is being paid on clinical quality metrics, it could be, cholesterol levels, it could be hemoglobin A1C levels, it could be, annual eye exam thresholds, it could be readmission rates, you name it. There are a whole set of clinical measures that are very good proxies for the clinical risk and managing that clinical risk and demonstrating how you brought down that clinical risk. There are a whole range of financial proxies like ER cost, the average ER cost across your patient panel, or it could be PMPM costs, or however the payers are working with the providers to break it down. These are metrics that are actually going into value-based care contracts. They could start out at the lower end, and as the relationship deepens, it could actually range into bundles, delegated carve-outs, all the way shared risk, all the way to full risk, assuming full risk for certain subsections of the population. You see these myriad levels of models, range of models across the country. Put yourself in a provider's shoes. How are you going to manage these contracts? Because every payer will have their own flavor. You'll have the CMS flavor, you have the local Aetna flavor, the Cigna flavor, the local Blues, the state Medicaid. Everyone has their own vision of how their population needs to be managed. And you as a provider, how can you do that if you are actually not having sophisticated technology to guide you through it? And you need one platform to manage all these populations. And that's where I think payer-provider collaboration really thrives with a dedicated PHM, because EMRs are not equipped to handle contracts. They are not equipped to handle what an Aetna is saying with respect to services. They are just focused on, okay, if this is the treatment of a diabetic patient, these are the pathways you should follow, and and they help the doctor do the prescription and the treatment, but they're not helping provide intelligence around, is this eligible, is this the right one, what does this do to lower the risk profile, etc. And that's where a dedicated PHM platform really helps drive that. Now, because one final thing is, because these are all on the same platform, we are seeing payers and providers collaborate in a couple of sense. They're trying to get at the data to establish the baseline. Okay, let's agree that the patient's risk is based upon this claims data and then the following EHR data. Once you have the baseline, they then agree upon the goals to achieve. Okay, let's make sure our wellness checks are going to be at 95% of our patient panel this year. Our readmit should be at 11%. And then the workflow then determines what is actually achieved. But because you're on a web-based platform, the payer and the provider are able to get the same view of the data and arrive at the same conclusion. Yeah, we did a good job. We actually reduced the all-cause readmission rate to 11%. We got our wellness rates to 95%. To me, that is true collaboration. When you get on the same page, I do not see that happening with the EMR-based PHM platforms anytime soon.